Hi, I'm Dr. Charlie. I'm a lead GP and a senior university clinical educator. In this video, we will discuss familial hypercholesterolemia. We'll explore the use of Simon Broome criteria in diagnosis based on NICE Guideline 2008. We will discuss assessment and management in primary care. Coming right up. Familial hypercholesterolemia is an inherited disorder when there is a very high level of cholesterol in the blood. It can lead to early development of the coronary heart disease. It is a common autosomal dominant inherited condition, and we think up to 1 in 250 people in the UK will inherit an altered gene. In heterozygous familial hypercholesterolemia, the patient would inherit a defective gene from one parent, and in homozygous from both parents, which is a bit more rare. The condition affects the cell membrane LDL receptor, and as a consequence, the LDL is less able to be removed from the blood. Familial hypercholesterolemia should be suspected in patient with total cholesterol of more than 7.5, or a patient with personal or family history of first-degree relative with myocardial infarction under the age of 60. In primary care case finding, familial hypercholesterolemia can be seen in patients under the age of 30 with total cholesterol of more than 7.5, or over the age of 30 with total cholesterol of more than 9. When the condition is suspected, we should perform additional blood tests, including non-fasting full lipid profile, renal function, liver function, thyroid function, and HbA1c. If the level of triglyceride is more than 2.3, familial hypercholesterolemia is less likely. You want to assess and manage hypertriglyceridemia. If the level is less than 2.3, you want to follow with assessment using Simon Broome criteria. 1. Ask for a family history of myocardial infarction in a first-degree relative under the age of 60, or in a second-degree relative under the age of 50. And also ask for a family history of total raised cholesterol of more than 7.5, either in first or second degree relative. 2. Check for tendon xanthomata, which can be seen as a deposit on the ankle or in the knuckles of the hands. If any of this is positive, you want to refer the patient to Lipid clinic. Definite familial hypercholesterolemia is seen in the group of patients with raised cholesterol and positive tendon xanthomata. Possible familial hypercholesterolemia is seen in the patient with raised cholesterol with the positive family history group. There is a scoring system from Dutch Lipid Clinic network which help identify likelihood of familial hypercholesterolemia, and I will leave this in the description below. Consider secondary hypercholesterolemia, including hypothyroidism, cholestatic liver disease, HIV, nephrotic syndrome. Also consider conditions that may contribute to hypercholesterolemia, including excess alcohol, diabetes, or even be on certain drugs such as corticosteroid or antiretroviral. Referral to Lipid Clinic will provide additional testing, including genetic profile and also cascade testing for affected relative. Consider performing ECG and assess CVD risk, including obesity, smoking, alcohol, and blood pressure. In primary care setting, you want to offer high-intensity statin, such as atorvastatin 20 mg once daily, and then ezetimibe. You want to achieve a reduction of LDL level of 50%, aiming for the LDL level in primary prevention of less than 2.5 and in secondary prevention of less than 1.8. You can check out more information about hypercholesterolemia, statin and statin-related muscle symptoms in my previous video. Lipid Clinic can offer additional treatment including fibrate, bile acid sequestrant, niacin, PCSK9 inhibitor such as alirocumab. I hope you find this video useful, and why don't you check out my other video on diabetes, hypertension and hypercholesterolemia. Don't forget to like and subscribe to my GP Team Academy channel, and until next time.